Bismillahirrahmanirrahim. Today I am discussing shock, and this is the third lecture of the shock series. Shock. Shock is a state of organ hypoperfusion with resultant cellular dysfunction and death. Mechanism may involve decreased circulatory volume, decreased cardiac output, and vasodilation, sometimes with shunting of blood to bypass capillary exchange bed. Symptoms include altered mental status, tachycardia, hypotension, and oliguria. Diagnosis is clinical, including blood pressure measurement and sometimes measurement of marker of tissue hypoperfusion, for example, blood lactate and base deficit. Treatment is with fluid resuscitation, including blood product if necessary, correction of the underlying disorder, and sometimes vasopressor. Pathology of shock. The fundamental defect in shock is reduced perfusion of vital tissue. Once perfusion declines and oxygen delivery to cell is inadequate for aerobic metabolism, cells shift to anaerobic metabolism with increased production of carbon dioxide and elevated blood lactate level. Cellular function decline, and if shock persists, variable cell damage and death occur. The inflammatory and clotting cascade. During shock, both the inflammatory and clotting cascade may be triggered in area of hyperperfusion. Hypoxic vascular endothelial cell activate white blood cell which bind to endothelium and release directly damaged substances. For example, reactive oxygen species, proteolytic enzyme, and inflammatory mediator, for example, cytokine, leukotrienes, tumor necrotic factors. Some of these mediators bind to cell surface receptor and activate nuclear factor kappa, which leads to production of additional cytokine and nitric oxide, a potent vasodilator. Septic shock may be more pro-inflammatory than other forms of shock because of the action of bacterial toxin, especially endotoxin. Septic shock. In septic shock, vasodilation of capillary vessel leads to cooling of blood and hypotension because of relative high hypovolemia. That is too much volume to be filled by the existing amount of blood. Localized vasodilation may shunt blood past the capillary exchange beds, causing focal hypoperfusion despite normal cardiac output and blood pressure. Additionally, excess nitric oxide is converted to peroxynitrate, a free radical that damage mitochondria and decrease ATP, adenosine triphosphate production. Blood flow to microvessels, including capillaries, is reduced even though large vessel blood flow is preserved, and in setting of septic shock, mechanical microvascular obstruction may, at least in part, account for such limitation of substrate delivery. Leukocyte and platelet adhere to the endothelium, and clotting system is activated with fibrin deposition. Multiple mediators along with endothelial cell dysfunction markedly increase microvascular permeability, allowing fluid and sometimes plasma protein to escape into the interstitial space. In the gastrointestinal tract, increased permeability possibly allow translocation of enteric bacteria from the lumen, potentially leading to sepsis or metastatic infection. Neutrophil apoptosis may be inhibited, enhance the release of an inflammatory mediator. In other cells, apoptosis may be augmented, increasing cell death and thus worsening organ function. Blood pressure is not always low in the early stage of shock, although hypotension eventually occurs if shock is not reversed. Similarly, not all patients with low blood pressure have shock. The degree and consequence of hypotension vary with the adequacy of physiologic compensation and the patient's underlying disease. Thus, a modest degree of hypotension that is well tolerated by a young, relatively healthy person might result in severe cerebral, cardiac, or renal dysfunction in an older person with significant atherosclerosis. Compensation for shock. Initially, when oxygen delivery is decreased, tissue compensates by extracting a great percentage of delivered oxygen. Low arterial pressure trigger an adrenergic response with sympathetic mediated vasoconstriction and often increased heart rate. Initially, vasoconstriction is selective, shunting blood to the heart and brain and away from the splanchnic circulation. Circulating beta adrenergic amines epinephrine or epinephrine also increase cardiac contractility and trigger release of corticosteroid from the adrenal gland, renin from the kidney, and glucose from the liver. Corticosteroid enhance the effect of catecholamines. Renin stimulate volume retention and vasoconstriction, increase glucose, increase pyruvate uptake in the mitochondria, which increase lactate production when there is insufficient oxygen. Reperfusion following shock. Reperfusion of ischemic cell can cause further injury. A substrate in reintroduced neutrophil activate many increasing production of damaging superoxide and hydroxyl radical. After blood flow is restored locally, concentrated inflammatory mediator may circulate to other organs. Multiple organ dysfunction syndrome, moods, it is also called mood. The combination of direct and reperfusion injury may cause moods, multiple organ dysfunction syndrome, progressive dysfunction of more than two organs consequently to life-threatening illness or injury. Moods can follow any type of shock but is most common when infection is involved. Organ failure is one of the defining features of septic shock. Moods also occur when more than 10% of patients with severe traumatic injury and is primary cause of death in those surviving more than 24 hours. Any organ system can be affected, but the most frequent target organ are the lung, in which increased membrane permeability lead to flooding of alveoli and further inflammation. Progressive hypoxia may be increasingly resistant to supplemental oxygen therapy. This condition is termed acute lung injury or if severe acute respiratory distress syndrome (ARDS). The kidney are injured when renal perfusion is critically reduced, leading to acute tubular necrosis and renal insufficiency manifested by oliguria and a progressive rise in serum creatinine. In the heart, reduced coronary perfusion and increased inflammatory mediator, increased tumor necrotic factor and interleukin-1 may depress contractility, worsen myocardial compliance and down-regulated beta receptor. These factors decrease cardiac output, further worsening both myocardial and systemic perfusion and causing a vicious circle that often culminates in death. Arrhythmia may occur in the gastrointestinal tract, ileus, and submucosal hemorrhage can develop. Liver hypoperfusion can cause focal or extensive hepatocellular necrosis. Transmission and transaminase and bilirubin elevation and decrease production of clotting factor. Coagulation can be impaired, including the most severe manifestation, disseminated intravascular coagulation. So thank you. This was the third lecture of shock. In the next lecture, I will discuss the treatment. That will be the last lecture. Please subscribe the channel and write down your valuable comments for the improvement of the channel.